Good morning. I'm going to try it again. Good morning. Thank you. I'm Jennifer Lundblad with Stratis Health, also a member of the eHealth Advisory Committee, and I serve as co-chair with Marty LaVenture of the Minnesota eHealth Summit Planning Committee. And so I want to echo the welcome that Marty gave yesterday to you. Now my turn today to say thanks to all of you for being here for this very exciting event. I thought yesterday was a terrific day, and I hope you all left with the same sense of both new information and a sense of energy that I did. So thank you all, and welcome to day 2. As we get started this morning, I want to remind you of who the presenting organizations are for the eHealth Summit. Those include the Key Health Alliance, which serves as the HIT Regional Extension Center for Minnesota and North Dakota. The Minnesota eHealth Advisory Committee, the members of whom we recognized yesterday as we got started, the Minnesota Department of Health, and my organization, Stratis Health. We also know that events like this aren't possible without financial sponsors, and so I want to pause as we get started here on day 2 and thank again our gold sponsors, Health Partners, the Minnesota Department of Human Services, and the University of Minnesota School of Public Health. We so appreciate the financial support that they offer so that we can bring this event to you and do so at a reasonable price for all of us. So our thanks to those sponsors. I don't know if you spent any time yesterday. If you didn't, I hope you will certainly make some time today to visit the breadth and wealth of exhibitors that we have here this year. They're all listed for you on this slide. I know I made it partway through the list yesterday and intend to get to the rest of them as we have our breaks and various times to do that today. But I encourage you, they all have brought and put together very informative sets of materials and exhibits and are all eager to visit with all of you as we're all here attending. So please do make some time to do that. You know that we went to a 2-year summit format last year when we were celebrating the 10th anniversary of the eHealth Summit. And as Marty indicated yesterday, when we asked for your feedback at the end of last year, you said, keep it at 2 days. So that's a little overwhelming for a planning committee, I will say. We thought that was going to be a one-time exception. But based on that feedback and based on the kind of opportunities that 2 days gives us, we're really pleased to, again, this year, have the 2-day format. And today is one of those examples of what we can do more of when we have that extended time. So in addition to 2 different breakout sessions today, we also have what we introduced for the first time last year, which is the longer workshop format, where we're rolling up our sleeves together with peers to address some of the most challenging issues that you have and based on setting or interest or profession. And so immediately following the break this morning is when, again, that opportunity to roll up our sleeves and have a bit of that longer time together occurs during the workshop. So really pleased to be bringing that back. A longer format also allows us more time to be together as a full group for the plenary sessions. You know that we did that twice yesterday, both with the plenary sessions in the morning and then wrapping up with the panel at the end of the day. And similarly today, not only are we starting out together this morning, but we're wrapping up with what I predict is going to be another really engaging panel session that will bring our day to a close. So again, the 2-day format allows us to get into some of the really meaty issues in a more in-depth way. And again, I hope you feel and sense that as we're working together. So you see here again our theme this year, Connecting Communities to Advance Population Health. We talked a little bit at the end of the day yesterday in the plenary about how in the first few years of the summit, we really focused on adoption and implementation of EHRs. It had a much more technical feel to it. Now, while there's still the adoption and implementation push occurring, now we're talking about things like population health and health equity and care coordination. And so the theme that we chose this year and then the thread of the various sessions, whether they're breakout or plenaries, are really building and illuminating that theme. And I can't think of a better way with that theme to start our day today than with the keynote speaker that I have the pleasure to introduce this morning, Dr. Mitchell Katz. He is the director of the Los Angeles County Department of Health Services, So just pause there and think about that time difference. He flew in late last night, and so we were just joking that it's still kind of sleeping time for him. So, but he has a cup of coffee. I think he looks like he's good to go. So the LA County Department of Health Services is one of the nation's largest municipal health systems. It has an integrated network of 19 health centers and 4 hospitals, plus an expanded network of community partner clinics across the region and area it serves. The Department of Health Services annually cares for, now listen for this, 670,000 unique patients and employs 19,000 staff. So the scale and scope of what he's responsible for is quite extraordinary. His organization is doing some really innovative things. Perhaps he'll touch on those. They're doing some programs around housing for health, which is focused on the homeless in Los Angeles. They're also doing some things around juvenile justice and specialized medical services for children in foster care. Those few things just give you a sampling of the breadth of what he needs to be thinking about in his work. But what in particular brings him to us today is a special role that he had last year. He was a member of the Institute of Medicine, the IOM's Committee on Recommended Social and Behavioral Domains and Measures for Electronic Health Records. That committee, that IOM committee, issued 2 reports identifying domains and measures that capture the social determinants of health. And part of their goal was to inform the recommendations for stage 3 of meaningful use. So again, as you think about our theme around connecting communities for population health, it is very deliberate that we have brought Mitch here to join us today, not only given his role in Los Angeles, but given his role on the IOM committee. I will also say that the eHealth Advisory Committee, thanks to Bob Johnson, had the opportunity to have Mitch join us on a conference call at one of our meetings last fall. So I know all of you have probably been participated in meetings where someone is presenting via conference call and know what a challenging format that can be, right? There's a group of people who are together in person, and then the poor soul that has to be on the phone and trying to talk and can't see body language and can't read the room. But what I will tell you is he did an extraordinary job. It was as if he was there with us, even though he wasn't, and was so engaging and so lively that when Marty and I, at the next eHealth Advisory Committee meeting, were seeking, as we always do, ideas for keynote and plenary speakers, and we asked the eHealth Advisory Committee, it was almost as if in a universal chorus of, Mitch Katz. So, no pressure. Please join me in welcoming Dr. Mitch Katz. Thank you.
Thank you. Good morning, everyone. I'll try to be as engaging in person as I was on the telephone. I must have had a lot of coffee that day. Well, it's wonderful that you all came out to this conference, and Minnesota is so far ahead of the curve because of all of you on a variety of electronic health initiatives. And so it's an honor for me just to be before you. I wanted to engage in your big picture theme of population health and do 2 examples. One, which Jennifer was talking about from the work of the IOM on social and behavioral determinants, and then also give you an example from LA of how we've used eHealth to bring our community closer together on a more medical care example, eConsult. I want to make sure, I assume you've covered this, but I want to make sure that we're all engaged on the what does it mean. They told me, by the way, so John was excellent, that if I accidentally press this button, the whole presentation would go away. But that in fact, if he's right, I really haven't destroyed anything. And if I press it again, it will all reappear. John, it's not reappearing. Okay, John. All right, very good. Really is there, huh? Okay. So I wanted to make sure that we're all talking about the same thing. What is population health? Well, really it involves, to my way of thinking, 2 critical ingredients. One is that you have a population. Now, there are a variety of populations. Population could be all of Minnesota. Population could be all of Minneapolis. Population could be all of a particular neighborhood of Minneapolis. It could be all of the patients seen in a particular hospital. What it cannot be is the patients I just saw in clinic, right? And that's important because almost all of medical care is based on the patients I just saw in my practice, right? In the sense that when people are looking at how do I reach people, they're thinking about who came, right? And one of the critical parts about population health is you don't just worry about who came, you worry sometimes more about the people who didn't come, who need the services, but for whatever reason, those services were not available to them. And then the second aspect, which deals very much with the social and behavioral determinants of health, is what's the distribution of outcomes, right? So Minneapolis may have overall great health if you look at a summary measure of the city. But what does that mean about specific populations within Minneapolis? What you want is to see that the whole community is healthy when you find large disparities that suggest areas to work on. Okay, so still on the biggest picture, so what determines the health of a population? These would be the five major determinants. Genetics, which everybody is very interested in. A lot of New York Times articles. The only problem is we can't change it, right? I mean, our genetics, the genetics of the patients we care for, they're set, right? One of the fascinating things if you do research is often you want to make sure that you've collected the predictor, let's say a predictor like smoking status, before you measure your outcome, right? Say lung cancer, right? That's critical to all epidemiologic research. When it comes to genetics, it doesn't matter. You can collect the data at any time. You can look at somebody's genetics at 70 and correlate it with something that happened at 20 because it doesn't matter. That's your genetics. And I say that because people are so focused on it, and yet it's the one thing we're not going to modify, right? So if we're going to make the world a better place, at least under current technology, and I don't think I want to think about the other kind of technology, we're not going to be able to change people's genetics. Individual behaviors, which is where a lot of us start, okay, so if we want people to be healthier, right, we got to get them to change their individual behaviors. We got to get people to eat healthier diets. We have to get people to exercise more. We have to have people who are experiencing less stress because they're going to meditation classes, they're walking more, they're being more social. And certainly we can make progress around individual behavior. But all of us who have tried to exercise more or eat better or give up cigarettes know at a minimum how hard it can be to do those things, right? So clearly individual behavior is an area that's important to work on, and it's important to educate people about what healthy lifestyle is. But every clinician and person who's tried to lose weight knows that it's more than just knowing what are the right things to eat. So then social environment and the physical environment, then you realize, well, they're probably on this list two of the most modifiable things that you can do, right? You can change people's social environment. You can have communities where there's a lot of social interaction, where there are activities available, places that are walkable, places that do have good food that people can find, places that are free of toxins. And then conversely, and Los Angeles can often be a particularly bad example of this. At my office in Los Angeles, which is in the city center near a variety of highways, our office happens to be very close to the 110, one of Los Angeles's major highways. And they started doing construction right behind our building. And my first thought is, how great, it's an exit ramp. When I drive in, I'll be able to get to the garage quicker. It turned out that they were building housing. It was infill housing up against the 110. And I'm thinking, well, that's a terrible place to build housing, right? I mean, you talk about sort of the impact of particulate matter on increasing the rate of pneumonia, increasing asthma exacerbations, right? That's, terrible, social policy to be zoning things to allow residential against buildings. So in both the positive and the negative, right, what our environments look like not only affect our health, but importantly, many of the factors can be modified. And then healthcare. Healthcare clearly does influence health, but it's easy to think that it's the major impact because we have huge industries. But probably healthcare affects something like 20% of people's overall health. And many of the things, and I know this quite well as a practicing physician, taking care of adults especially, there are some wonderful things that healthcare can do. I remember the last time I was taking care of patients last October in our acute care hospital. An elderly woman was admitted, and at the time, she couldn't lift her head, off of her pillow, to say hi to me. She was, not sure where she was. She was not sure what was going on. She had an infection. We started antibiotics, and the next day she was up in her, bed and knitting, right? So you can still have even, in internal medicine for people in their 80s, you can still have, amazing success. But that isn't what most of medicine is like, right? Most of medicine is dealing with diabetes and heart disease and lung disease, and it's us. We deteriorate, all of us, right? That's the nature of a biological being, right? We are going to, fall apart. It's just a question of when and how, right? And so what medicine can do is attempt to make it both, later and try to modify things and hopefully help us, when our time comes for it to be peaceful and, not horrible. But in the end, medical care does not generally change major outcomes. Okay, so if we're going to sort of combine these two themes of let's talk about the social and physical environment and individual behaviors that are modifiable, and let's use our technology. Well, the big thing you first note is, well, we're putting all of this effort into electronic health records, including in Los Angeles, we're doing a system. We're lagging way behind you in this state and many places. Los Angeles was not an early adopter of electronic health records. But even when you go to the places that have the best systems, they generally don't capture any of the data on social or behavioral determinants. So here, we're largely admitting that healthcare affects a relatively small part of people's health. The larger parts are determined by social and behavioral factors, but we don't measure any of them. And so if you go to our electronic health records, you can find sodium levels and X-ray results and medicine lists and problem lists. And all of that is great information, but that's not really what's going to determine the person's health. And then if you want to know about the things that are likely to determine their health, generally those are absent from our electronic health records. So that was the task that the IOM committee worked on, that Jennifer had mentioned, how to capture social and behavioral domains and measures in electronic health records. So a large committee of people that included medical informatics people, included clinical people, included psychologists, and importantly, it included your plenary speaker from yesterday, David Ross. He's a terrific person. Okay, so the committee, John, I'm thinking that I'm not directing this to the right place. Anyway, the committee charge was to identify the domains for consideration by the Office of the Coordinator for Health IT for meaningful use. Why the focus on meaningful use? Well, all of us know that anything involving electronic health records is expensive. So first, we're anxious if we really care about social and behavioral determinants and there are going to be costs, it's always helpful when there are offsets. I know as somebody who works in local government, and I know many of you do, when I have to go to a board for approval, including when I had to go for the electronic health record, it was very helpful to say, we need to do an electronic health record, and if I do the electronic health record, we will get these financial incentives from the federal government, and if I don't do it, we're going to get these penalties. Now, if you actually looked at how much it cost me versus to do it, versus the penalties and the rewards, penalties and rewards were perhaps 5% of the cost of doing it. But the government hates to give up the 5%, right? So just realistically, when you have those kinds of incentives and penalties, it makes a big difference. And as we'll talk more about it, it also, the value would come from our all using similar measures. Because if part of the goal is to be able to, as we do in the healthcare sector, to benchmark ourselves, just as we do on quality measures, to look at behavioral and social determinants, we have to ask at the least similar questions and ideally the same questions. So we worked on the criteria for selection, the domains and measures, how to incorporate the measures, and how to link them to other systems. We looked at socio-demographic domains, psychological domains, behavioral domains, individual level and relationships, and neighborhoods and community. You can't read this, I can't read it, but you have it in the data, which is why I put it in here, because I knew that the presentations would be made available to people. I'll read you what you need to know. It's encouraging that it fits on one page. So this is what the committee came up with. Not only can I not read it there, I can't even read it here. So this is what the committee recommends. And you can imagine, I think, putting this into an electronic health record. Race or ethnic group. So in this case, something that every medical record already has, but people use it in different ways. So we went with the census definition. What is your race? So you are of Hispanic, Latino, or Spanish origin. Education. Something that most electronic health records do not have. What is the highest level of school you've completed? What is the highest degree you've earned? Financial strain. How hard is it for you to pay for the very basics like food, housing, medical care that you need? And part of why we chose this as opposed to looking at income is, first, it's less sensitive than income. Second, it doesn't require, income is always very complicated because then you have to know household size, right? So just knowing somebody's income is not very helpful. And then it still doesn't really tell you, right, whether or not the person is having strain, right? What the kind of income you need if you live in a city with high rent is very different than what you might need if you were in a rural place and could easily get housing. So we went for the financial strain. Stress. How often do you feel stress? And with the definition, stress means a situation in which a person feels tense, restless, nervous, and so on. We use a 2-item depression index, which people may have used here. It's a screening measure that's used by clinicians. 2 questions to ask about people's activity level, 2 questions to ask about smoking use, 3 questions that ask about alcohol, 4 questions that ask about social connection, 4 questions that ask about intimate partner violence. And then we include residential address, which clearly every record has, but as a way to remind people that then you can use the census data using geocoding. Once you have an address, you can tap into the census to be able to say what median income is in that census, as well as a variety of other indicators. So this is also published in the New England Journal of Medicine, and the citation is at the bottom on if you had the written version to be able to see. So this is what ultimately the committee's final work was, recommending that if, in fact, we could include these elements, then we would have a pretty full indicator of people's social and behavioral determinants. Now, those of us who are working in clinical settings may immediately, look at that list and think, well, gee, yes, it fits on an unreadable slide, but still, that's a lot of money and time to collect all of that data. So one of the first things that the committee identified is, well, all of those questions, in fact, with the exception perhaps of the intimate partner violence ones, could easily be in a self-answered piece of paper, right? Nobody says one has to do expensive solutions. Tablets are always nice if you can, give them to people and have them fill it out. But that we wanted to be clear in recommending it. We're not saying that you need a physician or a nurse or a receptionist to collect the data. Put it on a piece of paper, put it on a tablet. People almost always are waiting 5 minutes. Often they're filling out the kind of forms that all of us have filled out and assumed would be filed and never read. I recently had the experience of enrolling my daughter in public school, and I don't know what it's like here, but I wondered whether or not people without advanced degrees were ever able to get their children enrolled. It was like 16 pages of forms on all kinds of information. And of course, I just went to the school to enroll her. I didn't bring, all of her medical records, all of her birth records, and I had this feeling throughout while I was filling it out, which is the same feeling I have about medical forms, that as long as I wrote something, she'd get enrolled, right? That what I wrote was of no significance, but if that I left anything blank, the clerk who was going to page through was going to say, you left this part out, and my daughter would not get enrolled. But I think that people, these are not questions that I think people would look at and think that way about. I mean, they're questions that really show in some way, I think, caring. For example, asking people about social isolation, or conversely, the positive, asking people about how they're engaged, in their community in terms of whether they're going to church groups or community groups or members of their veterans groups. I think that's a very caring thing. I think it shows that a healthcare system isn't just interested in what your blood pressure and sodium levels are, that the system itself is interested in knowing other things about you. So we wanted to, help people over the barrier by making sure people understood these forms, that we deliberately chose things that we thought could be self-administered, so that the amount of time that anyone in the healthcare world would have to spend doing it would be minimal. That being said, also anyone who works in the healthcare industry knows that anything has a cost, right? Just having the piece of paper, having someone give the person the piece of paper or the tablet, recollecting it, connecting that into the record, all of those things do have a cost if someone is just entering the data. We wanted to remind people, of course, that some of the questions, especially the ones about things like intimate partner violence, are very private. People have to believe that their data is protected and not shared. Conversely, some things you deliberately want to be able to link, although not necessarily link in a way with name, but use address to link to census tract data to be able to make the database richer about that person, and that we recognize that for that reason, resources will be needed to make this happen. I wanted to give you a few examples of how I think this can be used, both individually and broadly. So I think a lot of times in clinical settings, people are just not thinking about these issues, especially my profession, physicians. We're really trained to diagnose and treat illness. You know, what are the signs of the illness? What are the diagnostic features? What are the tests somebody needs? What are the medications somebody needs? Really not well trained often in the broader context of people's lives. And yet, physicians are, as are nurses and pharmacists and the other people working in centers, are very caring people. If the doctor, nurse, pharmacist, social worker knew that the person sometimes didn't have enough food to eat, they would care and they would want to make a difference. But there's nothing about the average electronic health record that would tell you that someone at certain points in the month doesn't have enough food to eat, or is in risk of losing their housing or living on people's sofa. I had one patient of mine who came in using a electronic wheelchair, and he had a large, basically it was a pressure ulcer sore on his buttock. And I said to him, where do you live? And he said, his chair, right? Which is basically someone allowed him, he had no home, but someone allowed him to roll his chair into their garage. So at night, that's where he slept. But if you didn't know that, right, you wouldn't know that, of course, he has a pressure ulcer because he has no place to move, right? He's always on the chair, right? What he needs to avoid pressure ulcers is a home with a bed and someplace he can get out of his chair. So whether it's that kind of dramatic issue or it's a more minor issue of being able to know how much somebody exercises to give them a more thoughtful exercise prescription, having the data would allow clinicians to do a better job. As you sort of make it as using the theme of this conference in broader terms of population health, understanding what small areas look like is very important. Knowing that housing is particularly an area of the city where people cannot find housing, where patients are either exposed to hostile neighborhoods in the form of violence or toxic chemicals, or understanding that kind of small variation, you'd have to have the data. And that could also allow you to understand patterns of illness. I know a major issue in California and throughout the country that's been helped by electronic health records is surveillance for influenza, right? So we're able to use the data from electronic health records to look at things like number of people coming forward for respiratory illness, because most cases of the flu are not diagnosed based on any laboratory parameters. We just assume if a lot of people are coming for respiratory symptoms of cough and runny nose, fever, right, that a high percentage of them probably have the flu. But then if we want to look at other things like housing or exercise or diet, we don't really have any information. So we can't do the same kind of surveillance. So I think that there are an endless number of ways that if we could get this kind of data into our electronic health records, if it's made part of meaningful use, one of the things that will immediately happen is that the vendors who create electronic health records for all of us will include the questions. And they'll figure out how, whether in paper or tablet form, to enable us to have our patients fill it out. So I want to then leave the broader topic to spend the rest of my time giving you an example that is a broader one, but I think weaves into the same themes, which is eConsult. So eConsult was something that we developed actually first in San Francisco, where it was less a community solution because it involved many fewer providers. And now in LA, where it really is a population solution, in the sense at least of all people who are getting care throughout a large system connected to community FQHC providers. So what's the problem that eConsult was trying to solve? When I got to LA, I've been in LA now 4.5 years. What I learned was that there were huge waits for specialty care. Now that's actually a common problem across the US, and it's especially common among uninsured patients or patients who have Medicaid, which is what my system is almost overwhelmingly seeing, is people who had no insurance. We have a higher insured rate now because of the success of the ACA in California. But then they have Medicaid, and under both of those scenarios, it's often hard to find specialty care. So people were waiting very long periods of time. Someone came at a hospital, I think it was my second month, to show me that someone had gotten an appointment for a cardiologist in 6 months. And they're like, you have to fix this. We're giving appointments in 6 months. And my immediate reaction was, you know, I'm just learning about the system, but I can tell you it's wrong to give an appointment for a cardiologist in 6 months, right? Because in 6 months, the person's either going to be dead, or more likely, they will have gone for care elsewhere, or they didn't really need to see the cardiologist in the beginning, right? Or the cardiologist, again, if you go back to the humility that I think all healthcare providers should feel, I mean, most things are not changeable, right? And so, you know, we want to see a cardiologist, but, you know, in general, if you have serious heart disease, you have serious heart disease. There are only limited interventions, especially on a chronic level, that are going to make a difference. But regardless, it's wrong to give an appointment in 6 months. We had, and this I think deals with the population issue, we had very poor coordination between the county system and the federally qualified health centers and other community centers in Los Angeles. So we work with almost 200 other providers, given the size of Los Angeles, of all sorts, small, large, federally qualified, not federally qualified, faith-based, neighborhood-based, ethnic-based, and generally they provide incredibly high-quality primary care, very close to where people live, taking into account the cultural issues of different communities, but they don't have any specialty care. We, as a large system with 2 university affiliations and 3 emergency departments, 2 of which are major trauma centers, large teaching programs, we do great specialty care in these areas, but getting patients back and forth, very hard, especially with the correct information. I was telling you about the 6-month appointment. Of course, you would get exactly what you'd expect. So while the system felt that they were completely in need of more appointments because they're giving people appointments in 6 months, at the end, when 6 months came around, nobody would have a show, right? Because we're back to the same thing. They either died, or they got better, or they went to see somebody else. So you had this perfect world where, on one hand, there was never a timely appointment. On the other hand, nobody ever came to clinic, right? Because the appointment was given so long, who could even remember that you got an appointment 6 months ago? And very large variation in practice in terms of how people handled similar common situations. The old system was a mix of paper, fax. There was a computer element, but the computer element was basically like a typewriter. You were just typing in the referrals. The ones by paper or fax were, of course, illegible. But even the computer ones would be unclear why the person needed to be seen, right? So someone would be sent to neurosurgery, and it would say back pain, right? Well, you know, back pain as in you think this person needs surgery, and they need surgery immediately because they have a tumor on their spinal cord that's causing their back pain, and they're about to lose function, and that's an emergency. Or back pain as in the person has had back pain for the last 7 years and has already had previous evaluations, right? And the answer is no idea. They were just referrals. So then because the system was overwhelmed, we would actually pay people to review these forms and try to determine which ones needed to be seen and which ones needed to be seen urgently. But of course, the ones that would get kicked out, back to the point about, you have to worry about the patients you don't see. The ones that get kicked out were the ones that were illegible, right, or had the least information, which is not necessarily the ones that were least important. They were just the ones that had the least information, right? So if you wrote a very detailed one, people could judge it. If you just wrote, back pain, then people couldn't, even if the person needed it. Very long waits. And there was also no way to know, if you were a primary care doctor, whether or not the referral ever happened, right? So here, we would think we were just sending these pieces of paper off as primary care doctors. And, every time, I would give a referral to a patient of mine, I would say a silent prayer, if I felt the person really needed it. God, please help this person to get this referral. Right? I am filling it out, but I have no confidence that they will ever get it. But I'm asking you, please. I think this person really needs it. I don't ask every time. So we went to this new innovation called eConsult, which has been a huge success for us. And it's not a referral. It's not a take care of my patient who has back pain. It's a conversation between primary care doctors like myself and specialists. And a referral might result in advice, which is what happens about a third of the time. So a third of the time, a visit that would have once been needed doesn't happen. The cardiologist, the same patient, let's say they had congestive heart failure, and I would have once sent them to cardiology with that 6-month appointment for which they wouldn't have shown. Now the cardiologist writes back to me in 2 days and says, Mitch, why don't you increase the dose of, and tells me which of the medications the person is on to increase. Why don't you increase the dose of their ACE inhibitor? And I can do it. And often, especially for difficult patients, you really need the experience of somebody who does this all day long to say it's good to push this dose higher, but pushing this other medicine will not make a difference. Sometimes when I send out a referral, the person does need to be seen, but what the specialist will tell me is, Mitch, I'd happily see your patient, but to make the visit worthwhile, I need you to do a CT scan of their abdomen, or I need you to do a blood test. And I'm sure many of you with yourself or relative have had the experience of being sent to a specialist, and the first thing the specialist says is, well, I can't tell you till you have this test. Very common. Well, that's a wasted visit. And in a system like mine, where there's a scarcity of services, I can't have wasted visits, right? I have this long queue for visits. So even if the person needs to be seen, it's tremendously helpful to me to make sure that the first visit is not a waste. And that, in general, those run about a third. And a third of the time, the specialist says, yes, they need a visit. But then they can tell me, and it needs to be in 2 days, it needs to be in a month, or it can be in 3 or 4 months. Let's say a non-incarcerated hernia repair, right? Doesn't need to be seen that day. We're not able to to do that. We're not evolved enough that those would get immediate appointments. This is just to give you a sense of that this is more than just a clinical intervention, because in terms of our sites, we have 4 hospitals, 2 former hospitals, 17 of our clinics, 170 of our partner community clinics, 14 of the public health in Los Angeles, because it's so big, is its own department, 14 juvenile court health services, and 9 clinics in the jail. So 3,000 providers are sending in these referrals to 48 specialty services and 330 reviewers or consultants. So what might first seem like, oh, this is a clinical intervention, which it is, you can see really takes on the idea of a whole community. In terms of the advantages, this has really been a win for everybody. It enables the primary care doctor and the specialist to really collaborate. We get the referrals done quickly. We've been able to reduce unnecessary visits. The visits that we have are more useful. And for the first time, we get consult notes. So it's not just my praying anymore, but I actually get to see whether or not the referral happened, and I get the information. And I should say, since you're a techie crowd, I don't always talk about this. The technology is actually the easy part. We do this on a simple internet platform, nothing fancy. We in our system will then data dump the information into the electronic health record so that the consult is part of somebody's record. But the e-consult system is a very basic, we needed it to be this way because we had all these community providers that many of whom did not have any kind of sophisticated thing. So basically any storefront with internet access can log on to our system and put it in. So this is the wonder of Los Angeles. We do 13,000 e-consults every month, right? It just sort of boggles the mind. There could be, those kind of numbers in one system. And we are now averaging, get my little responsiveness in, 2.5 days. So now 2.5 days is not, remember, that's not the visit, right? But 2.5 days for the third of the patients where the specialist was able to give the advice, it really is like the visit. For the second third where the person needs something, it's really like the visit. And so I've eliminated all of those visits. And then for the last group, now at least, I don't have to worry that there are people out there who need to be seen immediately, and they're being seen in the same way as people who have chronic problems who could, in fact, be seen in 3 months. So I'm going to go to my last slide for a second. And I want to make sure that we have time for questions. One passed. Okay. So in general, we felt like this system has been a win for everyone. As a primary care doctor, I love it because not only do my patients get the care that they need in a timely way, but I get to be a better primary care doctor because I learn from the specialty consults. And so the next time I have the same question, I probably won't have the consult needed. I would be able, if I wanted to look up the advice that I was given, I could be able to look it up on the system if I didn't remember the particular dose recommendations or the lab test to send. The specialists like it because they don't they only see now the patients who really need to be seen, right? And I run as many public systems, many of you know. People who come to public systems are very mission-driven. They know there's a long wait for services. They don't want to then come in and see somebody who doesn't really need to be seen when they know there are all these other people who really need to be seen. And then the patients are the big winners, because not only do they get timely care, they don't have to travel. And travel in a place like LA, my county is 4,000 square miles, right? So you could easily, if you're low income, have to travel on 3 buses and have it take you 2 hours. Because, I mean, you'd never be able to provide specialty care in every neighborhood. That's just an unrealistic thing. So in a county, LA is both very urban, but the county includes some areas, you know, where you're driving along and you know, people are riding on horseback. So, I mean, it's a very variable area in terms of distances and how rural it is. So the patients get timely advice without having to travel. So I always like to end this by saying, well, so, you know, does everybody have access to an e-consult system, and why not? And of course, the answer turns out to be money, right? So most people, even though all of us in this room would benefit if our providers had e-consult systems that were this robust, most of us don't have access because specialists in this country get paid for visits, right? So if you get paid for visits, you're not going to be spending your time answering e-consults. The only reason we can do e-consult is we're an entirely salaried system, and we get paid from the federal government and our state providers overwhelmingly, not exclusively, but overwhelmingly, in some form of capitation or cost-based reimbursement. So I don't have to have a visit in order to be able to bill for the services. So between those two things, what we do in order to make this happen is I would just have a specialist who, say, one time had 8 clinics a week. Now they have 7 clinics a week, and they spend 4 hours a week answering e-consults. And they get quite fast at it because us primary care doctors, we keep sending the same questions, right? And they develop scripts, right, which get more and more detailed the more they do it, and the system allows the saving of the script. So pretty much if you consult with them, you know, on something they've been consulted on before, after they read it, you're going to get the script, which is perfectly fine. It isn't cutting and pasting because they really have read everything you've written, and then they're just giving you the answer because there are only, especially as the specialists get narrower and narrower, there are only certain questions that they're going to be asked. So I think it's a good way of coming back to say that healthcare needs to be organized around the needs of our patients, right? In the case of the social and behavioral determinants, right, if that's what is affecting their health, then those are the things we need to pay attention to, not just their sodium and blood pressure levels. And similarly, if we're really focused on them, then we need payment systems that are also focused on them, not payment systems that are focused on the physician providers and how they get paid. We have to change those systems. So I'm going to end here, and looks like I can keep us on schedule and still have 10 minutes for questions.
Thank you so much. I will encourage those of you who have questions to step to one of the 2 microphones that are placed in the room. And while we're doing that, I'll ask a question that popped to mind for me, going back to the IOM report and recommendations. Can you talk a little bit about, on the receiving end at ONC and CMS, what was the appetite and interest for what you put out there? And now we've seen the notice of proposed rulemaking for stage 3. Can you describe where you think that work landed and how it ended up based on the recommendations?
You know, I think that in terms of the CMS, I mean, the response that we got was very positive. People liked the fact that the final screen was relatively few questions and that it could be self-administered. I think they're still working on whether exactly the questions that will be included in meaningful use But the idea could be that even if they chose, say, 2 or 3 in the final meaningful use part, you could still then do a broader screen as part of it. It's more the idea of asserting that that social and behavioral determinants should be part of meaningful use.
Thank you. Karen.
Good morning.
Good morning. Is this on? My question was, to marry these two topics, do you use the eConsult system for behavioral or psychiatric consults so that you can integrate those solutions into your primary care? Okay.
So yes, I mean with all of these things, I mean the question of how useful it is depends, of course, on the scenario. Just to go before I do the psych, the first time someone told me that we were doing eye consultations, I'm like, what good is that going to be, right? Because as a primary care doctor, my ability to examine someone's eye very limited, right? I don't have all the equipment that they have in ophthalmology. But it turns out that based on what the primary care doctor says, we can often get the right kind of eye visit, right? That it's an eye visit for refraction of glasses versus it's an eye visit for glaucoma versus it's an eye visit for retinal disease. So we've had the same experience as we've moved this into mental health, right? We certainly don't expect that the mental health clinician can do a full assessment to determine a DMS-3 diagnosis based on what the primary care doctor writes on the sheet, and we don't have that expectation. Where we found it exceedingly helpful is either in the area of medications, especially, for example, a common primary care question to a mental health professional is, I'm seeing somebody with depression and I've tried this medication and they're no better. What would you do next? Would you push up the dose? Would you go to a different? And then also, what resources are available for this person who is suffering from post-traumatic stress syndrome, whereby you already know the diagnosis either because they've been assessed previously or because the circumstances are quite obvious, but you're a primary care doctor and you don't really know where you would next send them. But it's been working well in those areas. Good morning.
Good morning. I actually have a couple of questions. The first was these questions that you posed, these social determinant domains. Were there any considerations as to who or what practices asked those questions? Were they more medical, primary care based versus behavioral? Sometimes we find asking certain questions in a behavioral health setting or a crisis setting can be a bit impeding to that client actually keeping further appointments.
Sure. We certainly discussed it. We didn't come to any firm conclusions. I mean, what we all agreed on was that the setting that was most important to ask these questions was a primary care home, right, for adults or for kids. And
right.
It's a good time to say that when it comes to kids, usually these things are relevant about the parents, right, not about the kids themselves, yet they're growing up in an environment themselves, right, and so what that environment looks like varies. And also kids pose a different issue in that some of those things, like, say, education, obviously change, right? Well, after about 23, 24, usually education doesn't change very much. The assumption was that it would not be done in emergency rooms, right? That isn't the right setting. Although some people pushed and said, except for the fact that people are sitting, and while they're sitting, right, and waiting, especially it goes, I think, to the question to some extent of how we evolve. If the world is, with all these centers, is disconnected, if I go to emergency department A, but I'm really a patient over here in B, it's really of no value that I've answered the questions here. If I'm a patient of A and I go to emergency room of A and I'm sitting there, then maybe it would be good to fill that out, because maybe, in fact, I'm in the emergency room because I'm homeless, and the emergency room isn't going to be able to resolve that. But in an accountable care organization, a care manager is going to pick up my record, see that I was in the emergency room, look at the determinants and say, gee, maybe if we got this person housing, they won't keep coming back to the emergency room. So I think there was a feeling that while that isn't the major goal, and that isn't where you most want it, the whole world doesn't always work the way we would want it to work, where people are going first to a primary care for an intake before they need anything. We also acknowledge that while we're not thinking about this for specialty care, some of these questions are very relevant for specialty care. For example, if you had a kid with asthma, going to see a pulmonologist, you would care very much about these answers.
Okay, my other question is you talked a couple of times about how you married those with the census information.
Yes.
Did you find any areas where they didn't maybe flesh out, where there were some vast differences in the information you collected, or were they pretty spot on with the census, and is that something maybe we should be relying more on some of that information rather than trying to recapture that information yet again by some folks that are maybe already pretty vulnerable?
Good. So just so you obviously know more about the census stuff, but I'll take a step back and say, so when you're linking with census, you're not linking, of course, with their individual answers. You're linking with the answers of their small area. And there are census tracts, but then their census tracts can be shrunk into these mini census tracts. And the mini start to be generally a fairly homogeneous group. So you're able to find out what housing looks like in that area, what income looks like, and all of the things that we ask on the census. Now, you can have people who are quite wealthy living in low-income areas. You can have low-income people living in wealthy areas. So it's by no means 100%. But what's nice about it is that all you need is the address. And every health record, well, I shouldn't say that because sometimes people are putting in P.O. boxes. Sometimes people are homeless. But the medical records are pretty good about having the address. And once you have the address, there are computer programs that automatically geocode from an address. And once you have the geocode, you can have the census data back. And it was thought of. Again, I want to say on the sensitive information and the vulnerable populations, I think a lot of the importance is the context. Right? What you want people to feel is that you're asking about these things because you care, not because you're trying to learn things about them. And I think the success of providers at thinking that and feeling that and transmitting that will then affect whether or not people look at them and say, you're asking me a lot of personal questions that have nothing to do with my health, or isn't it nice that my doctor thinks, to ask, and just again to bring it to a clinical thing, one of the things I've always tried to do when I see people, especially if I see people who I have reason to believe might be more isolated, older people where they're not raising kids, I always ask them about social things, right? And it's meant to do two things. It's meant to say, first, I care about them as a person, right? They're not just somebody with symptoms. And because I believe that as humans, we're meant to have social interactions, and isolation is a bad thing. And if I say, what do you do on weekends? Do you belong to any organizations? And they say no, then it's an easy entree to say, well, are there any organizations in your neighborhood? Or, are there things you particularly believe in? Or have you thought about volunteering? And see whether or not there's a way just in that quick interaction to link them to things.
Well, I think that the first part of what you shared with us, the important, and I might even call it breakthrough, that we now have expert consensus on a select set of things we should be measuring and building into the EHR that reflect social determinants, is just so critical to making our next leaps forward. So thank you for not only sharing them with us today, but that had to be a huge volunteer commitment on your part, so thank you for that. And then the way you illustrated how you've taken that and done that work in LA is extraordinary, and I think a lot that we can learn from here. So thank you for being here with us. We so appreciate it.
My pleasure. Thank you.
Before we break, I want to take what I'm going to call the moderator's prerogative to share some recognition and appreciation here in the room. Senator Linda Berglund has been with us at the summit this year. She doesn't know I'm going to make these comments, so it's with a little bit of apologies for that. But Senator Berglund is a longstanding leader in Minnesota government, and in particular, during the course of her role as chair of one of the key committees for Health and Human Services in the Senate in our state legislature, she presided over that at a time when the eHealth initiative was launched. We had our first EHR grant and loan programs. The Minnesota health reform legislation passed. And so in so many ways, all that we're doing here today and yesterday are the fruits of her labor, and we know how important the public-private partnership is that we have to do the kind of work that we're doing. And so I had the chance to say hi to her yesterday, and now that I have the microphone today, I'm just going to ask her to stand, and let's all just appreciate the work she did in that leadership role. Thank you. So we are breaking now until 9:30, and then the routine is a workshop, lunch, breakout, and then we're back here together at the end of the day for a panel focusing on health equity. What I can tell you is don't miss it. So have a great day, and we'll see you back here this afternoon.